Hello and welcome. So glad everyone is here. Happy SIBO Awareness Day. This is a huge, huge deal. It's an honor for me to be here hosting today. My name is Siobhan Sarna, and I wrote a book called Healing SIBO, and I have SIBOSOS.com. And for the past 10 years, I have been working diligently with SIBO experts to get the word out so we can all not just have awareness, but we can all take action to help support our microbiomes and our SIBO and resolve it ASAP. My honor to have all of you here. Now, the SIBO Awareness Day 2026 is the second annual one, and we want to thank the organizers, SIBOawareness.org, and also Gut Microbiome Foundation for their incredible work of expanding the awareness, the education, the resources, the possibilities, and the hope. And Sadie is here. She says hello. She is my co-host, and the hope for resolving this really annoying condition that obviously has a lot of downstream effects, but also with the diligent work of many people, many of which you're going to be meeting today, we're going to hopefully be seeing a cure ASAP. So just lots of good vibes to everyone who's working on it. We're going to have a variety of speakers today. We're going to do some giveaways. So my very first guest is the esteemed Dr. Allison Siebecker. And I do have to say, she's one of my favorite people on the planet. Hi, Dr. Siebecker.
Hi. Good morning.
So a little
Thanks, Siobhan.
Hi there, Dr. Siebecker. Dr. Siebecker and I have been working together for 10 years, believe it or not. And she was doing this way before that as a true SIBO specialist. She's an award winner from her peers with already a Lifetime Achievement Award, in your 20s? And very, very early in her career, she already was really making waves and making sure that people around the globe know about SIBO, both patients and practitioners. Her website, SIBOinfo.com, has helped millions of people learn more about the condition. It has recently gone through a glow up, and so if you haven't been there lately, be sure to stop by. She and I at SIBO SOS, SIBOinfo.com, we co-produce a variety of events, and be sure to sign up for our newsletters, etc., so you can find out more. A lot of which are free. A lot of them have Q&As attached to them, so people can really get a lot of personalized attention. It's amazing what can be accomplished on the internet. So, Dr. Siebecker, I know that we have a lot of questions for you today. We're going to be doing an overview about what exactly is SIBO, small intestine bacterial overgrowth.
Okay. Well, the definition has changed over the last several years, believe it or not. And we now kind of have three types of SIBO we always had these types of SIBO, but with new names. So first of all, the basic definition is, it is what it sounds like. There are bacteria that are overgrown in the small intestine. There's a small intestine and a large intestine. We used to think that it was just like too many in the wrong place, because the small intestine is where we do our digestion and absorption of food. And if there's too many bacteria, they interfere with that process, which is what happens in SIBO, and it causes a lot of problems. But we have expanded the definition because we have these three types of SIBO that are based on the gases that the overgrown microbes make: hydrogen, methane, and hydrogen sulfide. And the methane and hydrogen sulfide type, it turns out they can overgrow in the large intestine as well. And so they had to change the names. So now what we used to call methane SIBO is called intestinal methanogen overgrowth, or IMO for short. And what we used to call hydrogen sulfide SIBO is now intestinal sulfide overproduction. So where the definition has changed is that now we know the same disease processes we were thinking of can be large and small intestine for two of the types of SIBO. The other thing is that Dr. Pimentel and his wonderful team, of which Dr. Razai will be here speaking later, have done a lot of work to figure out exactly which bacteria or microbes are overgrown in these different types of SIBO. And so we now have that information, which is really helpful. We didn't have that information when I first started in SIBO, right? So now that we know, we can target our treatments better, and it clarifies what's going on. So for the hydrogen type of SIBO, it's been identified that it's E. coli, and this is the non-pathogenic type of E. coli, more of the commensal type of E. coli. Klebsiella pneumonia, and a little bit of aerogenes. For the methane type, it's M. smithii, which is not actually a bacteria. Another reason for the name change, it's methanogen or an archaea. And then for the hydrogen sulfide type, it's really interesting. They were able to find that it's different bacteria in the small versus large intestine for the hydrogen sulfide type. So for the small intestine, it's Proteus mirabilis mostly. And for the large intestine, it's Desulfo Vibrio piger and Fusobacterium varium. And I know that all sounds like a bunch of gobbledygook, but just thought I'd share it because I think it's amazing information, you know?
It is an amazing set of details that was not available until they have been mapping that small intestine over there at the MAST program in Cedars-Sinai. So it's really, really impressive. And just if you know what's causing it, they can work on getting the lock and key solution, which I know they're actively working on every single waking day and minute. I know.
Yeah, and it was a big surprise, I think. Dr. Pimentel has always said it was a big surprise to him to figure out that it was just like one or two bacteria involved in this condition. That was surprising.
And he also talks about, on the many blessed times we've had a chance to interview him together, about how it's like a neighborhood and a gang, and that those bad players are acting out and ruining the neighborhood for everybody else. And when they do get under control, hauled off, whatever, removed, shall we say, then the garden, the neighborhood can come back into homeostasis,
Yeah.
which is so reassuring.
Yeah. Yeah.
That microbiome, a lot of us are very focused on it, and it is a microbiome condition. And that's what I think he told us. Someone came up to him and said at a conference, "You've brought the microbiome back to gastroenterology." And I just thought that was a brilliant statement, because I know from going to certain gastros over the years, there was no connection of the microbiome to IBS, SIBO, and all of that. So what are the symptoms, Dr. Becker?
Yeah, right. Of course, this is the thing that everybody focuses on and is so important. The hallmark symptom, the keynote number one symptom, is abdominal bloating. Another word for that is distension, basically when the abdomen swells out. And this always happens in terms of SIBO, pretty much after eating. And that's one thing we can say, is that the symptoms of SIBO come after eating. So it's related to food and diet, which is one of the most awful parts of the symptoms. Because then, as I'll explain with the other symptoms, we know that these symptoms are related to eating, and then we get afraid of eating, afraid of food, and we start restricting our diet and things like that. So that's the number one symptom. Then we have bowel movement changes, so constipation or diarrhea, or a mixture of the two. It could be that they alternate. Some days are constipation, some diarrhea, or it could be an odd just mixture, because bowel movements normality are defined by both their texture and the frequency. So you could have, say, the texture of diarrhea, but very, very infrequent of constipation. So this odd sort of mix, that could also happen as well. And then another terrible symptom is abdominal pain, or it could just be discomfort. And it could be severe pain, it could be mild discomfort. That's another thing that occurs, very unfortunately. Then there could be excessive belching or flatulence. A lot of people have a lot of flatulence with this condition. There could be nausea. And another one that surprises a lot of people is acid reflux. That's a common symptom with SIBO, is acid reflux. A lot of people walk around with that as really their main symptom, and they are not thinking about SIBO, actually. There also can be some mental or emotional impacts. Anxiety is really common, actually. There can be depression as well, but anxiety is more common in SIBO, and that's been shown in studies, and we see it clinically. So that's a good thing to think about if you are having anxiety or your patients are having anxiety, that it could be from SIBO, and that will go away when the SIBO is treated, and that it's not necessarily a personality thing. Some people think that they're creating it themselves or something like that, but there's physiologic processes that can create this anxiety, can wake people even in the night. And then there can be brain fog. And of course, last of all, fatigue. I mean, from everything I just mentioned, it's rather tiring. So
Right.
a lot of fatigue.
The microbiome impacts how we think, and how we think, how our mind impacts the microbiome. So to hear you say that it could cause anxiety and depression, and how many people are thinking, "Oh my gosh, I'm just having a lot of mental health issues." and they're going in a
Yeah.
different direction. So I'm really glad we're having this conversation.
Yeah, and people might just think, oh, I have a stressful life, and most of us do,
Yeah.
and that can cause all sorts of mood changes, and maybe it is that, but maybe it is related to this microbiome disorder of SIBO.
So those are some of the symptoms. And when should you suspect SIBO?
Oh, yeah. So this is something that I just wanted to share. These are ways to think about when it might be SIBO, because the thing is, those symptoms that I described, the core symptoms, pain or discomfort, bloating, and constipation or diarrhea, those are the symptoms of IBS. And these symptoms relate to many other diseases. There's so many other conditions that can have these symptoms. So I thought I'd just share some things to think about when it really might steer you more towards SIBO. So obviously those core symptoms and particularly bloating. And as I was mentioned, acid reflux. I think it's appropriate when we have the main symptoms of IBS, the main symptoms of SIBO, to think about SIBO in one of the top things we're thinking about because it's very common. But another thing is something I was just alluding to, which is when there are a lot of food sensitivities. If you or your patient has a lot of food sensitivities and or they've already begun restricting your diet, if you started doing that, I'll try gluten-free, I'll try dairy-free, all these different things. And then if you know about FODMAPs, I'll try FODMAPs. And within that, having a lot of food sensitivities, if you can notice, is it eating healthier that actually makes you feel worse? That's something when you want to think about SIBO. Like what I mean is you're eating a higher fiber diet, you're eating more salads, you're eating more raw vegetables. Maybe you start doing green smoothies, like raw green vegetable smoothies. That's a big thing. You switch from white rice to brown rice, and now you're feeling worse, right? Or you're eating more whole grains. And then some classic trigger foods for SIBO are onions and garlic, which of course are ubiquitous in all cuisines around the world,
So true.
and apples and stone fruits like peaches, nectarines, plums, things like that. So any of these things you've noticed are more what is bothering you, I would think of SIBO. Now, another one would be bringing it to some of the causes, which we haven't talked about, but we will. When your symptoms started after having food poisoning, because that's the most common cause of SIBO, and that is classic, right? And now sometimes it might not be right away, it might be like a month or so later. But if that's really the thing, the trigger that you can link it to, that is when you certainly want to be thinking about SIBO. And also just know that food poisoning has other names like traveler's diarrhea and stomach flu. So that's one. Another is when the symptoms develop after taking a proton pump inhibitor. This is a risk factor for SIBO. And a lot of people can link their symptoms to the proton pump inhibitors or opiate narcotic painkillers. So, given for some other reason, maybe a surgery or some back pain or something you're experiencing, and now your GI symptoms began. So think of those things. Another one is if the symptoms started after surgery, after abdominal surgery. That's another one to think about. And sort of a reverse thing is let's say you were giving antibiotics for some reason, like a sinus infection or a dental procedure or urinary tract, whatever. And now your GI symptoms got better. That is another reason to think about SIBO. It's not like that would happen for everybody, but there's certainly a subset of people where they're just, they're given the right antibiotic that's going to work for their type of SIBO. For some other reason, all their symptoms go away for like 2 weeks. So, and then just a few more that are about supplements. If you're taking probiotics, or your patients are taking probiotics that have a good amount of prebiotics in them, so that's things like FOS, GOS, MOS, inulin, arabinogalactan, larch, chicory, Jerusalem artichoke. There's probably more. Those are the main ones I could think of.
Yeah.
If that probiotic supplement with a good amount of those prebiotics, it worsens your GI symptoms. Or if you just took a prebiotic supplement, you just got FOS and were taking it, and it made your symptoms worse. And similarly, you take a fiber supplement. And a keynote here is if it makes your constipation worse or your patient's constipation worse. We think of fiber as a treatment for constipation, but in somebody who has their constipation from SIBO, and in this case it's EMO, the methanogen overgrowth, that's linked with constipation, the fiber can actually just feed. That's what all these carbohydrates and things are doing. They're feeding the bacteria, the methanogens, they're making gases, and those gases are creating the symptoms. And then the one last one I have is, what if you were given a gut healing supplement? You have these symptoms,
Yeah.
or you decide to take it yourself. It's like, I better do some gut healing. It's a great thing to do if that makes your symptoms worse. Because again, that has mucopolysaccharide carbohydrates that can feed these bacteria. Now, all of these supplements are amazing, but maybe just when you're in the height of your SIBO, it's not the best match. We just need to clear some of that SIBO, and then you'll be able to use these supplements. But these are just ways to suspect this could be actually SIBO.
I think what's also important to note is that often when the SIBO is resolved, those food sensitivities go away. Your fructose sensitivity goes away. So I just want to remind everybody that, like, yes, the terrain is important, absolutely. And on the other side of reduction of the overgrowth, the neighborhood, that can all come back into harmony. We love that part. And it happens typically automatically from having the bad players removed.
Yeah, absolutely. In fact, the gut, there are studies that show that for those people who get leaky gut from SIBO, which studies show about half of people with
Mm.
SIBO will develop leaky gut from it. I'm amazed it's not everybody that happens to. But after you just eliminate the SIBO and then they retest like a month later, there's no more leaky gut. So it's good
Beautiful.
to know, the body can heal on its own, homeostasis can return when we remove the offending situation, right? And we
Right.
can think of that like if we get a cut, our body can heal a wound, right? So same thing. If we remove what is actively creating damage inside the intestine, our body can just heal that wound up.
Great, great analogy. Okay, so let's talk about underlying causes. What causes SIBO?
There's a huge list of things, a really large list. So I'll just mention some. I
Okay.
already mentioned food poisoning. And this is, again, of course, the work of the fabulous Dr. Pimentel and team, Dr. Razai included, who will be here speaking. They spent years mapping out the exact like pathophysiology and mechanism to prove and show how food poisoning can lead to SIBO. So that is our most common underlying cause of SIBO, or cause of SIBO is food poisoning. But there are a lot of other causes as well. So some are medications. I mentioned a few when I was going over when to suspect. So, like opiate narcotic painkillers can lead to SIBO. Proton pump inhibitors are a risk factor. Usually, they're in combination with some other factors that could lead to SIBO. And actually, I talked about antibiotics making SIBO better, but antibiotics can also be a risk factor to create SIBO, believe it or not. So, those are some medications to think about. And I have to say, I've had so many patients that said they link their GI symptoms beginning actually after taking an antibiotic. So, it's the opposite of what I was saying before. But then we have a whole list of diseases that can lead to SIBO. So, there are a lot of common ones like diabetes, actually, hypothyroidism, which could be autoimmune, like Hashimoto's, or it could just be non autoimmune hypothyroid. So common, right? I mean, so common. Ehlers-Danlos syndrome, not the most common disease for people to know about, but it actually is a common disease. It's gaining more and more awareness. Very common to have SIBO with Ehlers-Danlos. Parasitic infection. So many people have parasites and don't know it. Even in our country, we think of it as maybe going traveling to a third world country and getting parasites, but parasites are common. Endometriosis is a disease that can cause SIBO very commonly. One that Siobhan and I see and deal with all the time is mold illness. So, mold intrusion into buildings, work buildings, home buildings, cars is extremely widespread, really like almost an epidemic. And many people's immune system can't tolerate that. Not all mold is black mold that we think of as being super serious. Some of it is, but there's all kinds of molds, and people can develop illness when exposed to these molds, and that can lead to SIBO. And the reason that Siobhan and I are always dealing with this is because we do tend to deal with a lot of people who have more difficult to treat SIBO,
Mhm.
SIBO that is not responding the way we would think it should to our treatment, or that is relapsing too much. And very often it can be mold illness that is causing that. It creates difficult to treat SIBO. And then just a few other diseases to keep in mind would be things like inflammatory bowel disease, that's Crohn's and ulcerative colitis, traumatic brain injury, which again, not a lot of people think about, but is an epidemic, believe it or not, Lyme disease and the co-infections that go with that, and Parkinson's disease. So many things, so many diseases can lead to SIBO. And then I want to just mention one other thing that isn't diseases per se, and that would be more of structural, anatomic situations. And probably one of the most common there are adhesions. And these are like scar tissue, scar bands that can form inside the abdomen. And they can form in such a way where they press on the small intestine and lead to an overgrowth situation. But adhesions are formed from things like infection. So maybe like appendicitis or inflammation. Appendicitis has that too, or trauma. If the appendix bursts, it has that. So that's a good example for all of them. But other things that lead to adhesions are surgery. That's why I mentioned if GI symptoms develop after abdominal surgery, or any kind of injury like a car accident or a sporting accident, a fall off a bike, things like that. Also radiation, hemorrhage, and endometriosis. So there, I've said enough things in a big long line
No,
and
it's
list,
good.
but
It's so
it gives
good.
you a sense of it, right?
Right. And someone's commented in the Q&A box GLP-1, which is definitely appropriate to be mentioning
Oh,
too.
thank you so much.
Yeah.
Yeah, we have two studies that just came out last May at DDW, which is Digestive Disease Week, the biggest gastroenterology conference in the world. And it happens every spring. And of course, this was, thank you for whomever said that. We have long suspected that since they came out, but we got the proof. So two studies showed that GLP-1s can lead to SIBO.
So just a big bow on this, the migrating motor complex.
I haven't
Like
even mentioned it.
I haven't even mentioned it. But so for those of you who are like, wow, all of these things, what's the one thing in common with all of those things, Dr. Siebecker?
Okay, so the underlying true physiologic cause within the body that causes most people SIBO is a deficiency of the migrating motor complex, or we call it the MMC for short. And this is just a form of motility or a form of peristalsis or movement that occurs within the small intestine only. This is not in the large intestine, just the small intestine. And its purpose is to clear bacteria that is normally there in the small intestine anyway, to clear it down and out, move it down into the large intestine, and then it gets excreted. So it is really the body's number one protection against getting SIBO. There are others, but it is there for a main purpose of making sure we don't accumulate this overgrowth of bacteria in the small intestine. And most of the conditions and medicines that I mentioned slow the migrating motor complex. Some of them damage nerves that are needed to perform that function. That's what food poisoning does, actually. Now, on the other side of the more anatomical causes like adhesions, we're talking there like about a blockage or like a partial obstruction. So that's like a physical, like a log jam in a river. And in a way, you can even think of the migrating motor complex sort of like that, in that if things slow down, your flowing river becomes like a swamp, basically.
And so when people talk about motility disorders, I remember I heard that word for the first time many years ago, and I went to my acupuncturist. I was like, "Oh, I have a motility disorder." Finally, like that was the answer. And she was like nonplussed. She was like, "Okay, well, what do we do about it?" Like she was not like, "Oh, you found the golden ticket, Siobhan." Even when it was like, "Okay, then after that, I found out about SIBO." She was still like, "Okay, but what do we do about it?"
Well, because this is the biggest issue is that if you have something that is damaging your ability to perform the migrating motor complex, how do you fix that? So it unfortunately becomes not so simple. If you can cure the disease that is affecting it, great. But some of these diseases, unfortunately, we have no known cure for at this time. There are always scientists and doctors working on figuring that out. But so sometimes it becomes, that's why we can sort of understand chronic SIBO, right? It can be a little bit more complicated. It's not the simplest answer.
And there's also ways to manage it. So let's say
Oh,
you do
yeah.
have an underlying cause that cannot be like a quick fix. There's, as I always say, 100% feeling
Oh,
better from a managed chronic condition like SIBO than untreated.
well, this is a really good point because we can mention this in a minute here, but we typically see 80 to 90% success or improvement when treating SIBO. So, like 90% symptomatic improvement is the goal and the norm. And that's incredible. And when you look at the statistics for the various treatments of SIBO, which have all been studied numerous times, we get into the 90% success rate, which is astonishing for any disease. So that's the super good news. Super
Yeah.
good news. There may be a complicated underlying cause that isn't the easiest, simplest thing to snap your finger and make go away, but that doesn't mean you can't live at 90% symptomatic improvement, right?
Right. Exactly. So, how do you know if you have it? How do you diagnose it? And then we'll cover the three main treatments. So, go for it. How do you know if you have it? What's the best way to diagnose it?
Well, it's super important that we do a test. We have two kinds of tests we can do that diagnose it, a breath test and a blood test. And we do need officially, according to the definition, to have a test to make the diagnosis. And that's because of what I talked about before. Those basic symptoms can apply to so many other conditions. So you can't just use symptoms alone. You can suspect, but then you need the test to figure it out. So let me mention the breath test first. That's the main test we tend to use is a breath test. And what we're doing there is just checking for those gases I mentioned in the beginning, the hydrogen, methane, and hydrogen sulfide. And we just have criteria that we use when we see there's a certain amount or greater, then we know it's SIBO of those gases. Those gases get made by the organisms. They diffuse across the lining of the intestine into the blood. The blood brings them to the lungs, and then we expire them out. That's how we can do a test. It's an indirect test for these microbes, that their presence is indicated by the amounts of these gases. And in particular, hydrogen and methane are only made by these organisms, not by humans. So if we see these gases there, we know. And for hydrogen sulfide, we make that gas too. Humans do, but it's the amount that indicates it. So the breath test is really easy to do. The hardest part is there's a prep diet the day before that nobody really likes because you have to sort of narrow down your foods for a day. But the test is very simple to perform, and the diet isn't terrible. It's just a bit of a nuisance. And then it's easy to perform. Most people do it at home. You could do it in a doctor's office or at a clinic or at a hospital, but a lot of people will just order in kits and do it at home, and you do it in the morning after you haven't eaten overnight. And it takes 2 or 3 hours. And it's very simple. You just drink a little substrate first, a sugar solution, and then you breathe into these collection tubes. So that's how we do the main test, right? So that's super important to do that. And then the other test is a blood test. And again, developed by Dr. Pimentel and team based on their work of figuring out about food poisoning. And this is a test that actually tests if you have SIBO from food poisoning, but it's also used just basically as a screening test for IBS or SIBO. So this is a wonderful test. It can be like a great first test for a lot of people. And if there are any primary care docs listening, it's a great test for primary care doctors to just run as a screening test to just get a quick sense, are these symptoms that this patient has, is this SIBO? Is this IBS? So if this test is positive, it diagnoses IBS, it diagnoses SIBO, and in this case, post-infectious IBS, which is just IBS that is formed after food poisoning. And then the other thing that's great about this test is that what is physiologically going on is there's deficient migrating motor complex. It's by the nature of this very test and the whole mechanism it's based on, it will diagnose indirectly deficient migrating motor complex. So then that's helpful because there are medicines that treat that. We didn't talk about that earlier. Prokinetics. So these are either natural or prescription agents that stimulate the migrating motor complex. And if you have a positive, like this is IBS smart test, basically, then you'll know prokinetics are absolutely needed and indicated. And that's helpful. And also it helps for patients to be compliant. They have a test showing they need that as a medicine. So very helpful test.
And then what about the aspirate?
Oh, yeah. So, of course, you can do a culture test, or even, I guess we could call it like a DNA test, but this is where you're getting an endoscopy, or if you're performing an endoscopy, you can take a sample and culture it out and see if there's overgrowth that way. Problem is, there are problems with this test. It's easily contaminated by bacteria from the mouth, the esophagus, or stomach. Anaerobic bacteria may not grow when cultured, which is why it's probably better to do DNA. And there's just some other things. There are bacteria that you can grab a sample from basically the lumen, or like the middle of the tube, but sometimes you need to see the bacteria that might be under a mucus layer. So again, Dr. Pimentel and Dr. Rosine team have developed a new way of doing this test, which is much more appropriate to figure out for use for SIBO. I don't know how well it's been adopted. I don't know how many centers follow the new procedure. It has been validated. So we just have to remember that this has always been used as the gold standard. but we always used to say it's not very golden. And so once Dr. Pimentel figured out how to improve this test, things got a lot better in terms of our studies. But that's not a test that we're going to be doing on a regular basis. It's more
Right.
like if you're going in for some other reason and you're getting an endoscopy, you can ask for this.
Right. If you have a positive breath test, would the blood test provide new information that would help with treatment?
I think so, because it lets you know that the underlying cause, or we could say the cause, is food poisoning. And then that lets you know that if you're traveling anywhere, to be extra cautious and preventative for further food poisoning. Because once you've had food poisoning, it's more likely to get food poisoning again. There are studies showing that. And you can worsen your own SIBO situation if you get food poisoning again. So you want to be extra careful to prevent food poisoning. So this might change some of your eating out habits. And there are things like you can take some of our treatments for SIBO, you can take them at reduced doses if you're traveling to a third world country or a food prone area, although food poisoning can happen anywhere. So I do
Right.
think it affects treatment. And also, you know that, as I said, you have deficient migrating motor complex. That can change treatment because, believe it or not, although we tend to use prokinetics all the time in SIBO, there are doctors that don't want to use them. They may not be fully educated on them, and they may only think that there are unsafe prokinetics because there are some unsafe prokinetics, and they may not understand there are safe prokinetics, and so they may
Right.
have something against that. This will really show that they need to use a prokinetic, hopefully one of the safe ones, that sort of thing. So I do think it affects treatment.
And so if the IBS smart test comes back negative, it doesn't mean that you don't have SIBO. It's just helping to understand the underlying cause and understand your migrating motor complex.
That's
Like,
super important. If you
right.
start with, thank you, Siobhan. If you start with that test and it's negative, it just means you don't have SIBO from food poisoning. But then I went over a whole bunch of other
Yeah.
causes, medications,
Yeah.
diseases, adhesions. You still need the breath test to figure out if you have SIBO from those causes. But, very often that test is positive. But then I still recommend using the breath test to know which gases are positive because that affects treatment and how high. Because we base our treatments, at least for two of our methods of treatment, on the gas type.
And even if you had food poisoning a really long time ago, it could still be impacting you today. So we
Yeah.
just wanted to cover that. Okay, so we have a little bit of time left, which is great because we want to pull up that algorithm and the overview of how it's treated.
Oh, yeah. Okay. So I got this ready to go. Let me share my screen.
And you can order the IBS Smart Test directly from Gemelli Labs. So there was a question about that. I just wanted to take that on.
And breath test too.
Yeah.
If you go to, Siobhan mentioned earlier, I have a free educational website called SIBO Info. And let me just get this big screen. I have a testing page that's just a resource for everybody that shows all the different labs and all the different tests and shows you how you can order these tests. Patients can order it directly, or doctors shows you everything you need to know about both of these tests are on that page. So siboinfo.com testing. Okay.
So, yeah,
Yeah,
this
yeah.
is gold right here. This is what Dr.
Yeah.
Siebecker and I call gold. Like,
So I just
everybody
wanted
pay attention to
to
this.
share this as an overview because what this is a variation of Dr. Pimentel's original SIBO treatment algorithm that he first published, I think, in 2006. So a long time ago now. That's 20 years. Amazing. But it's slightly varied by myself and my colleague, Dr. Stephen Sandberg Lewis. So let me just take you through it. It'll give you a map and a good sense of, because you're going to listen to other talks today that are going to talk about parts of this. So first, we suspect SIBO, which we've gone over based on the symptoms and those key indicators that I talked about. And then what a lot of doctors do and patients do is but without even knowing what's wrong yet, they don't know it's SIBO or not, they just try some things. Alter their diet, as I mentioned, try various supplements, enzymes, digestive tonics, things like that, probiotics, and see if that helps. And if there is not sufficient help, then it's time to figure out what's going wrong. So then we use the breath test, usually to diagnose whether it's SIBO or not. And if it is SIBO, then we have three treatment options that we can tend to use. So we have pharmaceutical antibiotics, we have herbal antibiotics, and we have elemental diet. And just in case anyone doesn't know what elemental diet is, it's a medical food beverage that typically comes as a powder. It's all our nutrients that we would need broken down into their most absorbable form. We mix it with water and we consume that for usually 2 weeks in place of meals. That becomes our meals. And so it's a 2 week course, similar to antibiotics would be a 2 week course. Herbal antibiotics is a little different. That's usually a 4 week course. It just takes a little longer to do the same thing. Now, off on the side here, I have follow a SIBO diet. We have different SIBO diets that have been created that are very successful at reducing symptoms. And we could bring that in anywhere along the line. If you haven't already started one, I usually recommend waiting until after you test. But if you've already started, don't worry. Now, after you treat, we usually put someone on a prokinetic. I mentioned about that before. It stimulates the migrating motor complex. And we're doing that just to stimulate that movement to help hold the amount of reduction we've done with our treatment until we assess. So then we assess. And if a person is 90% or more than 90% better, we consider that the goal. And we can move on to the prevention phase. Now, we have a prevention phase because there are many causes of SIBO that are chronic, as I mentioned. And if you have something that, a disease or something that is always there that is causing SIBO, it's like you're going to relapse. How often, though? It could be a really long time. It could be like a year. It could be longer, right? That you would be in remission. But this is why we think about prevention and why it's important to think about prevention, because there is statistically a good amount of people that relapse. So what we do is we use some form of a SIBO diet. We use a prokinetic, and then there are some other supplements and other things we consider doing for prevention. And then that's what we do, and we're good, right? And we can reassess if we want to stop some of those preventions over time. If a person does relapse, as I was just mentioning, then what we want to do is we want to really try and figure out what the underlying cause is if we don't know. And we want to follow the arrows around to the right and treat that relapse again with our options. Now, coming back to the bottom right, let's say a person is not better. So I'm going to judge that by they're less than 90% better. That is the perfect time to repeat the breath test because we want to reassess, is SIBO there or not? Because sometimes the SIBO is actually gone and yet they still have symptoms. So that means the symptoms are from something else. This is common in that people often have more than one thing going on at the same time, right? So there can be more than one thing happening. But very often what will happen is the test is still positive, and that just means we need another round of treatment. So something this algorithm indicates is SIBO is a condition that often needs more than one round of treatment as its initial treatment to get it gone. And that's a key thing to know. If someone's coming in from the perspective of just thinking of an acute infection that you give 7 days of antibiotics or 10 days of antibiotics or 3 days of antibiotics and it's gone, it will be confusing because for some
Yeah.
people, it works like that for SIBO. You do your 2 week course and it's gone. But for so many people, they're going to need a second or a third round just to get all that overgrowth gone. And that is normal and expected. So
And
there it is.
not well known. So I'm really glad you're saying that out loud. And I want everyone here to remember that because it's so unusual. We're so used to take this treatment, call me in the morning kind of thing, but the multiple rounds is so important. For retesting, Dr. Siebecker, how do you find it to be most efficient in terms of a time frame after treatment? And then we're going to dive into some questions.
I like it when people retest within about 2 weeks of finishing their treatment. And the reason why is because at about 2 weeks, if the SIBO is not fully gone, often people will begin to backslide. Their symptoms will start getting worse again. That's just because think of it like if you were treating an acute infection and you had a 7 day course of antibiotics and you took 2 or 3 days and you started to feel better. And so you're like, great, now I stop. It's just going to come back again. Like you weren't finished treating it. That's why I like to retest before that point. So a little bit before 2 weeks. Anytime within 2 weeks of finishing your treatment is good. Now, one thing I just want to say is there are a lot of gastroenterologists who recommend retesting at 1 month. These are gastroenterologists who aren't like SIBO specialists per se. And I think the thinking there is they want to prove it's gone. But that is not what I recommend using the retest for. I recommend using the retest to figure out where you're at with the SIBO that you've just treated, because sometimes the gases can change and you need to shift your treatment. And so you're actually using it as a treatment tool to help you get the SIBO gone.
Okay. All right. Let's come in for some questions for Dr. Allison Siebecker right now on SIBO in the SIBO Awareness Day 2026.
Yes, and by the way, I didn't yet thank the organizers. Thank you so much. Raising awareness on SIBO is like my life's career mission. So thank you so much for what you've done in creating this day and event.
It's a beautiful thing. Let's get it out there, everybody. Please, when you see this on social, share it, keep paying it forward, and let's get the word out. Can C. diff cause SIBO?
Yes, I saw that commonly before I actually realized it could cause it. And I used to just call it like post-C. diff syndrome. It's almost kind of like food poisoning in that they have the original symptoms of the C. diff, and then it just slightly morphs. It's like as if it never really went away, but it got a little bit better. It kind of morphed a little bit. Yes, I have seen many people that have gotten their SIBO from C. diff.
Wow. Okay. So celiacs are perfect candidates for SIBO, question mark.
Yes, I'm sorry, unfortunately. It's common. It's a common overlapping situation. And in fact, if you're celiac or your patient's celiac and they haven't been responding to a scrupulous gluten-free diet, meaning like you've checked for hidden sources and things, so often it's SIBO. They have a coexisting condition.
I also just, while we're talking about diets, this has come up several times here. The diets don't cure SIBO unless it's the elemental diet. Just wanted to point that out. It does, as Dr. Siebecker said, control symptoms. So you can feel much better very quickly, but it does not address the overgrowth. And the low fermentation diet, the SIBO specific food guide, the biphasic diet, the low FODMAP, all of those things are low fermentation. And so I just want to point that out because I see a lot of people in the SIBO SOS Facebook group getting very confused about that. I've been on low FODMAP for 6 months. I'm not better. Okay. That is because you still have SIBO, but hopefully you are feeling better on a daily basis because you're not doing the onions and the garlic and the apple and that kind of thing.
Yeah,
And
you need both.
you
You
need
need
both,
both.
right? And the long-term goal is to expand your diet, by the way. So that's just wanted to clear that up for anybody who is a little bit not past that. Okay, if you don't have those bacteria levels mentioned, high, if you don't have them high but have others, does that mean it's not SIBO? And I'm wondering if you're referring to a stool test because often when you get the breath tests back, they don't label what kind of bacteria you have.
Yeah, the breath test doesn't tell you the bacteria type. So what I would say is just get a breath test and then you'll know if you have SIBO or not. That's how
Right,
you know.
right. Can hydrogen type SIBO coexist with hydrogen sulfide type SIBO?
Yes, I didn't mention that we can have that there's a fourth type, which is
Mm.
mixed gases. It's very common to have hydrogen and methane together. That is like so common. But we can have any two gases together or all three. Absolutely.
Okay, I've done Trio Smart breath test and tested positive for IMO. Should I also do the IBS Smart test?
I think it's wonderful to do that. I would say yes, because you can figure out if your underlying cause is food poisoning. And I think that's so helpful to know. Now, one thing that's interesting here is that the studies on the blood test show that it more often becomes positive for those that have either diarrhea or mixed diarrhea and constipation. But it can also work for those with constipation. It's just that it's a smaller percentage of patients with constipation that their cause is food poisoning. But I have to say, in my experience, I've mostly used that test on constipated patients. It's a really good test also if you really have a mysterious circumstance for the
Mhm.
underlying cause. Like you've looked at all the causes, you can see them all on my website. I have a page on causes that lists everything. I didn't say them all. And you're like, this, none of this applies to me because a lot of people don't remember having food poisoning, believe it or not. If there wasn't vomiting involved, they may not remember.
Right.
And that test can come positive. So, yes, I would say it's a great thing to do.
Is it made worse by perimenopause and or menopause?
Yes, isn't that charming?
Isn't it lovely?
It's because of the hormonal changes. Yes, it's been shown in particular that menopause and perimenopause can amplify symptoms of IBS. And so, yes, we see this with SIBO.
Do you see a lot of patients who are sucrose intolerant because of chronic SIBO, or do you think that that sucrose intolerant was the underlying cause?
I don't see a lot of patients that have sucrose intolerance with SIBO by itself. What I particularly see from a clinical perspective without the test is that people who are intolerant to sucrose often have fungal or candida overgrowth along with their SIBO. In terms of sucrose intolerance, what comes first? SIBO could cause it. It's not common, but it could. I would suspect there's an underlying sucrose intolerance. I'm talking big picture here. I have no idea what's going on in this person's individual
Dr.
circumstance.
Siebecker is not your
But
doctor,
like
and this is not
I'm
medical
thinking, yeah,
advice.
I'm thinking big patterns of medicine here. It's not that common with
Y'all,
SIBO.
I just want to also say, because I see a couple of comments coming in, after you do treatment and maybe you do multiple rounds, that prokinetic is key to making sure that you prevent relapse going forward. That is in the 30,000 person Facebook group that I have. That is the biggest blind spot I see. Other than people saying, like, my doctor doesn't believe in SIBO, like it's a religion, things like that. I mean, literally, Dr. Siebecker gave me a t shirt that says, "Are you on a prokinetic?" for my birthday because I
I
say it
actually
so.
did.
She
I
really did. I
actually made
almost
her.
wore it today. I
I
almost wore it
actually
today.
made her a t-shirt.
But that is like, if you think you're doing everything, you've tried everything and all that, and you're not doing a prokinetic after treatment, you are absolutely setting yourself up for more frustration. So, okay, let's keep going. It's a personal pet peeve of mine, and partially because I didn't do a prokinetic because I didn't get it. And so I'm very,
And she had it sitting there at her house, by the way.
don't even ask. Okay. So, SIBO Awareness Day. That's why we're doing this. Yeah. Okay. When the underlying cause is mold, Dr. Siebecker, when it is mold toxicity, how long does it take to truly address the SIBO?
We can't make meaningful forward progress on the SIBO until the mold is cleared. We can get some temporary symptomatic relief from doing treatments. And so we do that. Many people will do that. Just while they're working on the mold, they'll kind of also treat the SIBO just to give themselves some relief. How long does it take to get rid of mold? I am not a mold specializing doctor, but it can be a while. 6 months, a year.
Yeah.
It's a thing you got to work on. And of course, you have to remediate the environment. And
Yeah.
what if
You
it's at
can't
your
still be
work?
living in it.
Or if
Yeah.
you have no other option and you're going to work in a place with mold, I'm so sorry. You really have to not have the mold anymore. So
Yeah.
you have to deal with the mold externally and internally. And when you deal with the mold internally, we treat the nose. There's always colonization in the nose. And of course, the digestive. And there's several pillars of it. We have wonderful colleagues that focus on mold. We have master classes on Siobhan's SIBO SOS site. You can take a look at those.
Dr. Jill Krista is one of those people.
Dr. Jill Krista, yeah.
And she wrote the book Breaking the Mold. So just think about the pockets of the microbiomes, like, your gut, your nose, things like that. They really hot spots for stealth infections and overgrowth. We're moving along, but I wanted to just touch back on the MMC. If someone has diarrhea, Dr. Siebecker, their doctor has told them that they don't believe, they won't give them a prokinetic because they feel like their motility is already too fast.
Well, such a good point you brought it up. As I mentioned, the migrating motor complex only occurs in the small intestine. And these are two different chambers that are separated by the ileocecal valve. And even if you had an absent valve or a dysfunctional valve, there are different processes that go on from the small to the large intestine. So the migrating motor complex does not travel through the small intestine, then into the large intestine to create a bowel movement. Migrating motor complex has nothing to do with creating bowel movements. So the most common scenario in SIBO, like diarrhea and hydrogen SIBO, that's the most common presentation of SIBO. And the most common cause of SIBO physiologically is deficient migrating motor complex. So that means someone has slow movement in the small intestine, creating the SIBO, creating the overgrowth, and fast movement in the large intestine, creating the diarrhea. That is the most common presentation of SIBO. So the different chambers have different motilities. Now, a super important point here is that a prokinetic is not a laxative. Prokinetics could have laxative effects. That is possible depending upon the dose and the type. But they are not laxatives. In their definition, the definition is not to create a bowel movement. Okay, whereas a laxative's definition is to do that, to soften stool and create a bowel movement. Prokinetics definition is to coordinate and amplify downward movement, typically of the upper GI organs. So they're used for the esophagus, stomach, and small intestine primarily. So this is the problem. Believe me, I teach at pharmacology conferences on prokinetics. The misunderstandings of prokinetics are great. And the lack of awareness and knowledge of truly the pharmacology of prokinetics is missing. So I'm so sorry. I don't know, maybe you'll be able to bring some articles to your doctor or explain this difference, but their primary effect is on stomach and small intestine.
Okay. What a great presentation. Thank you so much, Dr.
Thanks.
Siebecker. It was really, really great. There are a variety, by the way, of prokinetics, just to wrap that part up, that are some are natural, some are supplements, some are prescription.
You
SIBO
could just
Info,
go to my website, SIBO Info, and
SIBOinfo.com, and see a ton of it. Yeah.
go to the prevention page. You'll see them.
Dr.
Thank,
Siebecker, you're a fantastic teacher. Thank
oh,
you so
thank you.
much.
And thanks, Siobhan. Thank you for the organizers, and thank you for your wonderful questions. I loved them. Great.
They are great. Lots of love to you. Thank you
Okay,
so
and
much for
love
your
to
work.
Gary, the next speaker. Hi, Gary. Love to you.
Lot
Bye,
of
everybody.
great